So thanks very much. I'm excited to share some of the program of research that I'm working on with many trainees and staff and other colleagues on my team. And I also wanted to begin with the territorial acknowledgement. So I live and work on the unceded and stolen territories, including the territories of the Squamish, Tsleil-Waututh, and Musqueam First Nations. And I'm joining today from the territories of the Saanich, Cowichan, and Chemainus First Nations. It's really important that we begin this presentation with this acknowledgement, both to acknowledge whose land we're on, but also, also because many of the health and social issues that I'm going to be talking about today are inequitably experienced by Indigenous people. And here's some of the issues that I hope to delve into throughout my presentation. Of course, when I wrote the abstract, I said I would do a deep dive into all of these different areas. And in reality, with 40 minutes, it might be more of a surface level dive. But I think this will be helpful to have some breadth as we go through, as you'll see that many of these issues are very much interrelated. And I want to begin by talking about how I'm using language today. So I am very intentional and purposeful about the language I use to describe the populations that my program of research seeks to serve. I do use the term sexual, or I will today use the term sexual and gender minority people as a term when I'm talking about all different kinds of sexual and gender diversities. And I recognize that, this term is not without its limitations. It is also a contested terminology. And I encourage you to think through, as I describe the different populations that my team works with, how we use language. And I think sometimes we don't always get it right. So that's always a point for reflection. So to begin, I wanted to talk a bit about methods, and you're going to see as I go through this presentation today, I don't delve into methods too deeply. In fact, I do a bit of a quick overview over most of them, but I wanted to start talking about the community and participatory based approaches that my team engages with and give you some examples, and I'll give more examples later in the presentation. Before I jump in too deep here, I do want to just describe some of the ingredients that I see as essential to do effective CBPR. And that is that this work really needs to be community situated. So it's of importance to the community and it takes place in the community. It's collaborative, so it's working alongside the people who are affected by the issue of interest. It's for, this is by and for the people we're serving. And it's action oriented. So there is some kind of outcome from this work that we really want to use to advance change. And this is invariably around social justice oriented change. So those of you who work in CBPR, this won't be surprising. I wanted to start with the example of a study that I partnered on with the Community-Based Research Center in Vancouver with the Investigators program. So the Investigators are a group of young sexual and gender minority men who are interested in health research. And they approached my team about 2 years ago to partner on a community-based qualitative study examining the experiences of young gay and queer men with their experiences accessing pre-exposure prophylaxis. So they had some important questions when they came to my team, specifically about how this really important intervention that had become available via the provincial pharmacare program for those who are eligible in January 2018. So some of them had been able to access PrEP and others had just experienced some challenges doing so. So in 2018, we developed a partnership. And my team and I worked closely with the investigators to deliver a series of skills and competency-based workshops focusing on qualitative research. So including things like study design, the development of research questions, how to use NVivo as a data management platform, and of course, data analysis. And we ended up deciding to conduct for this work in-depth semi-structured interviews with sexual and gender minority men who have either accessed PrEP or who were thinking about it. And the aim here that we developed was really to identify strategies to improve access to PrEP. So the investigators were mentored by experienced interviewers on my team, and together they co-interviewed 27 participants. And just a shout out to any trainees here who might be training at UBC SPPH, we actually use this data set as an opportunity to learn how to do data analysis in vivo when I teach qualitative methods there. So each investigator, and there were 10 in total, identified their own analytic question to ask the data repository we developed. And there's a full community report available on the Community-Based Research Center's website. And here I wanted to show you by way of example, a one-pager from Nick Galliano, who also subsequently went on to do a research placement with my team to further advance his analysis. And I think that his analysis, I wanted to feature it here. It was just accepted in AIDS education and prevention. It's such an important example of how community-based approaches allow us to identify novel insights into data. So what Nick really identified was the extent to which not only was PrEP, a valuable resource for the young men in this study in terms of preventing HIV, but he also identified the profound mental health impacts that the availability of PrEP was having on this sample of men, specifically with regards to eliminating, either reducing or some did describe eliminating HIV-related anxiety. So for those of you who do work around gay and queer men's health, you will know that this is a really important piece of gay men's mental health, the HIV-related anxieties associated with sexual health. I think it's really important as we do our research, and this was a really foundational sort of piece to doing this work with the investigator, is doing this equity-based analyses and considering who could be left behind with this intervention as we conducted the work. And we know this is important because we know, for instance, that Indigenous people are not taking up PrEP to the extent that other populations are. And we know that we know this in part from how this is reflected in continued rates of HIV acquisition among different populations. And we also know that in 2016, which was 2 years before BC and other provinces made PrEP available, that PrEP was available for Status First Nations and Inuit people, and that there was what my colleague Harlan Pruden has described, a complete implementation failure in terms of getting this effective intervention to those who need it or who could benefit from it. So moving into another topic, but very much related, I want to talk about cis heteropatriarchy and how this influences experiences with primary care. And here I'm going to give the specific example of sexual health care. And so I've got two examples of papers that, they're both a bit older. The one is from 2012 and the other is from 2014. But the lessons learned from this early work hold true to this day. In this paper on the left, one of the pieces we identified here through interviews with 50 young men of various sexual identities, so including straight, gay, bisexual men, we learned that the heteronormative assumptions of clinicians in clinical encounters were negatively affecting both the queer identified participants as well as the straight identified participants. So for many reasons that are not terribly surprising around heteronormative assumptions for queer folks, which would also often result in stigmatization, judgment, misclassification of risk assessment, was also occurring, but in different ways among straight guys. So we heard, for example, that straight guys accessing care, wanting to get an HIV test, for example, were often not given that test when they would seek it, because their clinicians would assess either their sexual behavior, so with what gender they're having sex with, or their sexual identity, and not recommending further testing. So really a missed opportunity. You know, the title says it all here, heteronormativity does hurt everyone. Of course, there are disproportionate impacts for those who are not straight. This has a knock-on effect for those who are providing care. And the second paper on the right was from data collected across the province of British Columbia with providers of sexual health care for young people specifically. We've continued to collect, and we continue to this day to collect data with providers. So the lessons learned from this one really ring true to this day. And, you know, for me, when I look at this paper, I remember conducting these interviews across BC and learning that healthcare providers often feel dreadfully unprepared, lacking the competencies and skills to provide appropriate care for their sexual and gender minority youth clients. With that said, and this is where I suppose the silver lining is, most of them wanted to learn. They were craving, they wanted opportunities to learn, to enhance their capacity to provide sexual and gender affirming care. We see that even to this day in work when we're talking to people about, to clinicians about providing substance use care, for example. They want to learn, they want to provide good care. Not all, of course, but I would say for the most part, you know, the clinicians want to do better with this population. So I would be remiss not to do a bit of a plug-in or shout out to an educational intervention that was developed by my team. I think it went live about 1 year ago. That is featured for free for if folks are interested in taking it on UBC's continuing professional development platform, where we consulted community, we did environmental scans and brought it all together to develop a set of guiding principles, as well as modules on how to actualize these kinds of principles in the provision of care. It happens to be in the area of substance use care, but it could equally be translated in many other domains. Oops. So next I wanted to go into another topic of interest on my team, and that's around alcohol and gender. And for those, I'm sure most of you are aware of the kinds of low risk drinking guidelines that that even we see here in Canada, where women are recommended to usually drink, in most guidelines around the world, to drink half as much as that of men. So if women are recommended to have 1 drink, then men would be recommended to keep it to within 2 drinks per day, although this differs depending on the guidelines. So as researchers working in the area of trans-inclusive substance use treatment and care, AJ Lowick and myself, so AJ is a PhD student at UBC, and I were interested in the rationale for how these gender-based low-risk drinking guidelines are determined, including we really wanted to take a look at these rationale with an eye to how science and evidence is mobilized. And in examining the rationale in our environmental scan, to support these kinds of guidelines for people of different genders, we identified how sex-based biological factors are often used as a set of crude assumptions about men and women's bodies, including that all women are smaller than men in terms of body mass. And in our scan of the guidelines, we were only able to locate 1 low-risk drinking guideline for trans people, which indicated that trans men, regardless of their use of hormone replacement therapy, should follow the low-risk drinking guidelines for women. So we suggest that most guidelines are based on biological sex rather than on gender. and that the evidence for sex and or gender-based low-risk drinking guidelines is itself scarce, vague, and inconsistently used across different jurisdictions to inform drinking guidelines across the world. So why does this represent a problem? I'm sure for many of you, you already are recognizing this, but we're concerned that rather than being evidence-informed, these gendered low-risk drinking guidelines are far more reflective of and are contributing to gendered stereotypes in which men's drinking patterns are normalized while women's are moralized. So in our work, and in these two papers that we published, we've argued there's an ethical prerogative that we attend to the concepts of sex and gender correctly as we develop clinical and public health guidelines, which will undeniably have an impact on the individuals and societies who rely on them. I also wanted to go into the topic of the overdose crisis and drug policy. And of course, I recognize that many of us on this call will have lost someone to the overdose crisis. So I want to give time to recognize this as we go on. I also want to emphasize or re-emphasize a call for action that myself and my amazing colleagues on this paper put out a couple of years ago, really arguing that we need better data in this area with regards to sexual and gender minority people. We don't have the best data available, particularly from a surveillance or population level perspective. But what we do know is that regardless of the substance we're looking at, and regardless of the study, invariably sexual and gender minority people, if we are measuring sexual and gender identity, experience higher rates and more harms associated with substance use. And this is indeed occurring with regards to the overdose crisis as well. What we do know, thanks to the work of Trevor Goodyear, a PhD student in the School of Nursing that I supervise, and based on an analysis that Trevor conducted with 50 young sexual minority men in Vancouver, is that the navigation of risk is occurring in ways in which they're highly aware of the risks. There's a lot of anxiety and people are scared. In this paper, we found, in this analysis, we found that the queer and trans men in this study were actively taking up various, what I would refer to as individualized harm reduction strategies. And I purposefully use that term. These are strategies that they've developed and derived on their own. They're not strategies that public health or various facets of the healthcare service delivery system have brought to them. So it's things like carefully sourcing where they're getting their drugs from, trying to find trustworthy sources. So whether that's going on the dark net and reading reviews about suppliers of illicit substances, or finding someone else they can trust, using with friends or peers. What we also know from these findings is that the public health oriented harm reduction strategies, so whether that's a safe consumption site or drug checking services, don't necessarily feel like services that are for this group. And they told us the reasons why, and it had everything to do with geography, to not being culturally competent services around sexual and gender identity. So it's not necessary, they want services that would be more sexual and gender identity affirming. There's anxiety about accessing these services and experiencing some kind of homophobia or transphobia. I also wanted to, so while we're on the topic of drug policy, is to talk about some of the work that my team has done with regards to crystal meth in young people. So this was really a project and a study that was catalyzed by the Youth Advisory Committee that works with my team. And this team is coordinated by Rodney Stair, who's pictured here in this picture, working hard with the Youth Advisory Committee. And this Youth Advisory Committee is comprised of QT BIPOC, so queer, trans, Black, Indigenous, and other people of color, young people. So Rodney came to me a couple of years ago and offered the recommendation that this Youth Advisory Committee should be comprised of people of color in order to more fulsomely address the inequities that we know occur along the lines of ethno-racial identities within the queer community and within sexual and gender minority communities. So in January 2020, the Youth Advisory Committee, myself, AIDS Vancouver, Vancouver Coastal Health brought together 17 sexually and gender diverse youth between the ages of 15 and 30 who use crystal methamphetamine from across Metro Vancouver or Greater Vancouver. And the aim of this summit was to catalyze a community dialogue about how the lives of those who use meth can be improved. And so the Youth Advisory Committee developed a variety of individual and group-based activities at this summit to get at three main questions. There's a full report available, by the way, for those who are interested on the BC Centre on Substance Use's website. So they ask questions like, what doesn't work? So here they identified big challenges they have with regards to meth use around accessing supports or programs, things like the contaminated drug supply, stigma, barriers to care, aging out of care. We asked what works. So here youth identified supports and services for youth that do work, like peer-based services, like harm reduction services, community connectedness, and housing and employment opportunities. And then we asked what's needed. So here, the youth participants identified things like treatment options, more active outreach, compassionate care, and the acknowledgement that comorbidities exist in the design and delivery of services. Right, so this is the report. If you'd like a copy of it, either contact me or you can find it just by Googling Side by Side Summit. And I'm really pleased to let you know that these findings have been presented to Vancouver Coastal Health and Fraser Health, and Vancouver Coastal has, as a result of some of these findings, prioritized young people and sexual gender minority people as priorities within the stimulant strategy they're developing. And a big shout out to Vancouver Foundation. We were successful for 3 years of funding to continue this work around young people and crystal meth. So I'm just going to look at the time. I told Andrea to let me know if okay, so I've got about 12 minutes before I'll get a shout out from Andrea. I want to go into sexualized use of substances and talk a little bit about the work that we've been doing on my team here. So for those of you who aren't aware, sexualized use of substances is I guess it's a topic area that's generally tends to focus around gay and queer men, gay, bi, queer men. And this is because we know a lot of drug and sexual related harms do occur based on specific configurations of how drugs and sex are brought together. So it's usually including crystal meth, GHB, and other substances, but those are, tend to be the two primary substances that go together. There's a lot of health outcomes or harms, I mean, that can occur from this. I also want to emphasize not all people who use drugs with sex experience harms, and not everyone needs intervention. But some do, and some want intervention, and some want to reduce harms. And I've written previously about the need to advance science in this area, the need to integrate care in this area. I've also, based on somebody who was very close to me a few years ago who was experiencing harms related to crystal meth use, to really identify what is the state of knowledge, what do we know about intervention, what are the effective interventions in this area, specifically for this population of gay and queer men. And you'll see here, I've used men who have sex with men in the title. So it's interesting how we use language to characterize the populations we're serving when we're talking to an audience, like in this case, a peer-reviewed publication. So alongside my fabulous colleagues here, we did identify through a systematic review that there really are limited opportunities to intervene, specifically around crystal meth use among this population. In some ways, it's not surprising. We don't have good pharmacotherapies regardless of the population for treating or addressing crystal meth use related harms. There are some psychosocial interventions that have a limited or moderate efficacy. We don't really know how this plays out after the intervention ends. So things like contingency management can be quite effective or efficacious during the intervention. What I found interesting here was we didn't really end up with any harm reduction related interventions in our review. And I think this is an area where, as scientists like myself, we can really advance some science and hopefully some intervention in this area. And as my colleague Dania Fast always says, we need to stay close to the data as we think about this kind of as we think about what people want and what kinds of interventions might work. And Natasha Parent, who's a PhD student on my team, conducted this really thoughtful analysis, looking at how cannabis use features within the sexual lives of young sexual minority men. And what we were finding as we were collecting these data is that there's a really deliberate and intentional use of cannabis that has many of the ingredients around the rationale for using that we know and that we're also hearing about crystal meth is used with sex. So things like using cannabis to enhance pleasure and intimacy, for you to experience euphoria, to behavioral disinhibition, so not being anxious around being with new sexual partners. I think, one important piece from this study, and I do not want to overstate the findings, but we did have some guys tell us that they were using cannabis instead of crystal meth. So they weren't using it as a replacement strategy, but they were going into contexts where party and play and chemsex was occurring, and they were instead using cannabis. So, I think this raises a lot of questions around how we can advance science and thinking in this area, not just around cannabis use, around other strategies for harm reduction as well. And so Olivier Ferlat at Université de Montréal and myself recently received CIHR funding to do a Quebec, British Columbia comparative analysis or comparative mixed method study looking at sexual and gender minority young people and cannabis. So this is one of the questions we'll be moving forward with. Anybody who knows me knows that I'm very much interested in drug policy as it pertains to queer populations. And in this case, poppers is a really important one. Poppers or alkyl nitrates is a substance that can be inhaled. It's often used with sex by gay and queer men. And one of the important side effects, so you can experience some euphoria when you take it. One of the other side effects is it can relax soft muscle tissues, so it can make receptive anal intercourse either painless or less painful. So it's used a lot within sexualized contexts. Health Canada cracked down on poppers in 2013 and prohibited the selling of poppers. And so while we know through really important repeat cross-sectional work like the Sex Now survey done by Community-Based Research Center that we've seen the prevalence of poppers use tends to be somewhat stable over time, even before and after the crackdown. We didn't really know what this crackdown was doing for the experiences and perspectives of those who use poppers until Cameron Schwartz conducted this study with, I think there was about 30 young sexual minority men in this study who described using poppers. And they described that they are using poppers with an enormous degree of uncertainty, and that the current approach, the current regulatory approach, does not allow them to find safe formulations of poppers. And this is important because some formulations do not have a safety profile that would or have a very low safety profile, whereas others are quite safe. So they're not able to find the formulations that would be the most safe in the current regulatory context. So, you know, this is a really important area for myself and many of the community-based partners listed here. We have been in conversations with Health Canada about how, well, first we asked, why did this occur? It was a bit of a black box for us, why in 2013 this ban or crackdown had been enforced. But we also wanted to learn, how can this be changed given the current regulatory context? And you know, anybody dealing with Health Canada knows nothing happens overnight. Health Canada, I think, is you know, they're a system that really wants to see randomized controlled trial data or things like that. But from my perspective, this is a homophobic policy and it needs to be changed, and it behooves Health Canada to be consulting community when these kinds of crackdowns are imposed and disproportionately impacts populations like gay and queer men. So the last section that I want to go through with you is around mental health. And I want to give some findings from the Heads Together survey, which is a survey led by Pierre-Julien Coudot, who is a postdoctoral fellow who works with myself on my team at UBC. I want to give an important content warning. I will be going through some suicide and suicide-related data. So the objective of this study was to really describe mental health and substance use related health outcomes among sexual and gender minorities living in Canada. And we pivoted our objective or our question, research question, to really focus this as taking place in the COVID-19, because COVID-19 became a public health crisis just as we were getting ready to launch. So we conducted a cross-sectional online survey across Canada among those who are over the age of majority. It took place from June to early October 2020. We recruited 512 diverse participants, primarily through online recruitment techniques. And as you can imagine, we're up to our ears in data analyses right now. The median age was 29, so people of all ages were included in this survey above the age of majority. 63% of the participants identified as white, 9% as Indigenous. You can see we got participants from across the country, although we did have some challenges in the North and the Atlantic. But nevertheless, we did succeed in recruiting a very sexually and gender diverse sample, providing us with very real opportunities to do to examine between group differences. So for gender identity, a quarter of the sample identify as trans, and then we have 25% as gay, 23% as bisexual, 19% as queer, 11% as lesbian. For context, I wanted to show you some brief descriptive findings related to COVID-19. So 41% indicated they were socially isolated for more than 90 days, while 30% said they did so alone. And the strategies they're using to cope feature things like talking to friends and families on calls, with some indicating they're using formal care services. General mental health and well-being was not great. I want to emphasize these findings are not representative, so this sample is not generalizable to the entire population of Canadian SGM. But nevertheless, I think it offers important glimpses into what's occurring. So using the patient health questionnaire 9 score, we also found moderate to severe depression in 57% of respondents. And this is where some of the outcomes become quite concerning. So when we asked about suicide ideation in the last 12 months, 45% responded yes. And among those, 59% indicated it occurred in the last month. When we asked about a suicide attempt, 6% indicated yes. And of those, 38% indicated an attempt had occurred in the past month. So this is concerning. We know before COVID, suicide outcomes inequitably affect sexual and gender minority people, and these data, suggest this could be worsening, and it's really important that we continue to study this, and with with an eye to intervention. One of the questions we had was how close to that what we characterized as a stressful and traumatic context, so during the lockdown measures, was there something around closeness in time to that period that influences outcomes? And we did find that those who experienced moderate to severe depressive symptoms or suicidal thoughts were more likely. Those we recruited during sort of early summer, June to July last year. But what I think the important piece here for me is that these mental health challenges are continuing over time.
Rod, I just wanted to let you know it's 12:40 now. And
thank you. So I'll be done in 2 minutes. So thank you for the warning. While all of that may seem bleak in terms of what can be done, particularly when we're facing syndemics, so these co-occurring health outcomes, many that we talked about today, things like substance use related harms, mental health, sexual health. It's important to emphasize we do have evidence-based strategies in our toolkit to improve health outcomes. We know, for example, that from the survey that Olivier Ferlat led with almost 3,000 Canadian sexual and gender minority people, 94% were interested in learning how to recognize signs of suicidality. 81% of those indicated a preference to learn skills online. And of course, we need comprehensive action on this front, including large-scale structural changes, whether that be enhancements to the provision of formal and informal mental health supports, or things like changing law, like banning so-called conversion therapy. And this is, I think, my last slide, but I want to do a shout out to Camp Out. I was privileged enough to be able to co-found Camp Out in 2009. And this is the kind of social health education intervention that really can change lives. They've had over 1,000 young people between the ages of 14 and 21 attend the camp each summer. And we know from these testimonials that many young people who have went to this camp would not be here today had they not had these kinds of opportunities. So I want to say thank you. Thanks to my amazing team. Thanks to all the funders, community-based research partners, and that is all.